the nuance when it comes to discussing 5-alpha reductase inhibitors, I would argue there's probably three potential use cases for them. One is around hair loss. If someone doesn't have acute effects from using a 5-alpha reductase inhibitor for hair loss, is that potentially going to lead to health ramifications long term? I think one of the contested points in the hormone replacement therapy space is DHT as a paracrine hormone and the impact of circulating DHT on prostate cells.
When you're talking about 5-alpha reductase inhibitors, you're not really talking about blood DHT levels or serum DHT levels. You're thinking about its effect in each organ system in the body.
All right. Dave?
Yeah, so firstly, big thank you to Carl for coming on and talking about this. I know that a lot of people have been wanting to hear, I guess, a informed and respectful conversation from both sides of the fence. I find that that is often a paradigm that is immensely lacking in many online communities. And I think the value that people are going to be able to take away from this is to be able to have an informed opinion about a medication they may already be taking or may be thinking about taking. And I think if the recent years have taught us anything, it's the importance of informed consent when it comes to taking medications. And I try not to be dogmatic in approaches, but I'm a little bit dogmatic on this approach, but I'm also of the stance, firm beliefs held loosely as opposed to loose beliefs held firmly, which I think a lot of people have. I am very open to changing my mind. Recently, I had a great topic with a memo from Marek Health about the potential use cases for enclomiphene, and I was actually convinced on that, which was something that I've been quite I guess, ignorant to in terms of, to use a correct term for that. So my approach for, I guess, the nuance when it comes to discussing 5-alpha reductase inhibitors, I would argue there's probably three potential use cases for them. One is around hair loss, preventing hair loss, which I think most people on the channel are probably going to be looking at. The second would be as a prostate cancer prophylaxis. And then the third would be for treating prostate cancer that has already been developed. I have very little understanding, and I would argue no place talking about the third. It's not in my wheelhouse, and I'm not going to pretend that it is. I think it's very unbecoming when people speak outside of their lane, so I don't want to do the same thing. My, I guess, perspective on DHT, and I'm going to start this actually when we I need to grab my phone to do that. I was devastated when I lost my hair. It was one of the most difficult things I went through in my early 20s, but it certainly wasn't one of the most difficult things I went through in my life. At the time it was, though, because I was very young. I was in a band, I had long hair, I used to straighten it and dye it. I cried the day I went to the barber and had to shave it off. It was very difficult. So for people who have the perspective that, some people are more attached to their hair than others, I was very attached to mine. And I'll send Stephen some videos he can, for photos maybe you can put up on the screen. So I think that when guys are looking at using a 5-alpha reductase inhibitor to block 5-alpha reductase, which doesn't just block the production of DHT, it also, 5-alpha reductase does other things in the body. It's important for degrading cortisol into dihydrocortisol so it can be eliminated. It's important for the production of allopregnenolone, as well as the metabolites of DHT, which is 3A, I'm probably pronouncing this wrong, androstenediol, and 3B androstenediol as well, which all have important biological functions. And I would like people to be able to make the informed decision as to whether the benefit of keeping their hair for the cosmetic and potential psychological implications that come with that, it's an uncomfortable thing to go through, hair loss, is worth the potential ramifications and repercussions for their biological health, potentially if there can be issues where after discontinuing the medication, the side effects may not resolve, which is this syndrome known as post-finasteride syndrome, which some people debate about. I guess the most important kind of overarching point that I would like to address today is that my concern is that if someone doesn't have acute effects from using a 5-alpha reductase inhibitor for hair loss, let's say they're like, well, my libido is good, like, I don't really have any problems. Is that potentially going to lead to health ramifications long term that they might not be aware of, things happening now that could be causing problems downstream? I think that's worth looking at. And I guess overall, the importance of guys understanding what the prevalence of these side effects are, what the different percentages are in terms of how often they come up. I've seen some people say it's 1%, 2% of guys get side effects. In some studies, it's up to 15% get erectile dysfunction. But the other side of the coin, and Kyle did a great video the other day on GLP-1. And he said, he gave this perspective of saying, well, if there are risks to using GLP-1s, those risks are likely outweighed by the benefits of resolving obesity due to the risks that come with obesity in these contexts. And I think that that's a very valid counter argument for using pharmaceuticals. I would just be concerned that healthy men would be sabotaging their health and for the sake of something that's not actually life-threatening, that's just psychologically uncomfortable. So that's my perspective on that. And then I also, I guess, question whether the benefit of blocking 5-alpha reductase for the potential development of prostate cancer is warranted, and if it is as beneficial as stated. And we can go through the trials which they have assessed that.
Mm-hmm. Yeah, on the channel we have discussed with several people this post-finasteride syndrome, with a lot of long-term side effects and ramifications for them. But yeah, Kyle, you prescribe it for men with hair loss. You still do. I don't dare to prescribe it anymore.
If you've just started TRT, it is completely normal to feel overwhelmed and confused. There's a lot of new territory to cover, and there is a lot of conflicting information. I wrote TRT 101 so that you can have everything that you need to know in an instruction manual in one place that you can refer back to, that you can have all the questions answered before they even come up. TRT 101 is my best practice approach for TRT from start to finish, and it contains everything that you need to avoid all the challenges and pitfalls that I've seen come up in my clients over the last 5 years. You can check it out via the link below.
Yeah, rarely I will prescribe finasteride in some cases, but for most individuals, I prescribe oral dutasteride or topical dutasteride, and often there's benefits other than hair loss. For example, they might be on a non-physiologic androgen regimen, which all androgen regimens, including testosterone creams and gels, are non-physiologic unless someone's applying the cream as you sleep. But occasionally there is a secondary benefit. For example, less DHT driving erythrocytosis, or less DHT driving left ventricular or right ventricular hypertrophy, or the prostate benefits that we have previously mentioned. But the way that I prescribe it, I don't know if you guys are familiar with bipolar androgen therapy.
No.
Bipolar androgen therapy is used for castration-resistant prostate cancer, which is kind of like inverse finasteride or dutasteride syndrome, where there's a patient that has prostate cancer, they've been chemically castrated, and perhaps they've even taken an adrenal steroidogenesis cascade inhibitor as well. And it has continued to progress. And they actually use supraphysiologic doses of androgens, like a steroid cycle. And a lot of the same phenomenon happens that you see in males that take steroid cycles. They take 400 milligrams, and then and they actually continue to give them 400 milligrams of usually testosterone cypionate or enanthate, so half-life a little less than a week. And they give them one intramuscular injection every 28 days. So they purposefully spike up the testosterone and DHT supraphysiologically, even in patients with prostate cancer. And they continue to do that until there is progression of disease because of the androgens. So they've resensitized this patient's tissue, prostate tissue in this case, but other genitourinary syndrome tissues can be resensitized, as we do in patients. I think we all take care of, or at least Dave and I take care of a lot of patients with post-finasteride syndrome, as we do similarly in those cases in various ways. And then as soon as there's progression, then they end the bipolar androgen therapy. So you can do it the opposite way. Rather than give them supraphysiologic androgens, let's say there's a patient that is on, they've discussed with their physician the risk and the benefits of a higher than physiologic range testosterone replacement protocol. For example, 200 milligrams of cream or gel per day, or 200 milligrams of injectable or subcutaneous testosterone per week. And they want to attenuate some of those side effects because they are having benefits. Let's say their profession requires them to continue to do so. Maybe they're a strongman competitor. And for the same reason why you do the shared decision-making process, which is the same way I approach it, risk and benefits, as Dave mentioned. The same way that you have that conversation regarding their testosterone replacement therapy or the various options regarding it, you have that same conversation regarding adding in a 5-alpha reductase inhibitor. Maybe it is, maybe it's one pill once a week, and then you take a month off. That's your, 1 month on, 1 month off, and then during the month off, that's kind of your, or 2 weeks off. That's where your total androgenic load, or androgen pool, as I call it, is quite high, and then you're resensitized purposely to androgens during that point.
Mm-hmm. What do you think, Dave? Could Kyle convince you to advise men to take a DHT blocker again?
When I've reviewed, I think one of the limitations that we have in most fields regarding relatively novel pharmaceuticals is that we don't have lifelong or more than 10-year follow-up studies where they look at a guy's overall health outcomes. We tend to look at a couple of variables over a couple of years, or we look at a couple of variables over 10 years, but it's not like we're running these comprehensive health panels and doing this thorough investigation as to what happens. And I think one of the contested points in the hormone replacement therapy space is DHT as a paracrine hormone and the impact of circulating DHT on prostate cells. There's a study titled "Dihydrotestosterone Administration Does Not Increase Intraprostatic Androgen Concentrations or Alter Prostate Androgen Action in Healthy Men," a randomized control trial, if people want to look it up. Essentially, it was double-blind, randomized, placebo-controlled. They took 31 healthy men between 35 and 55, and they gave them supraphysiological DHT levels by gel. So 7-fold increase to baseline levels. And the findings were, quote, robust supraphysiological increases in serum DHT associated with decreased serum testosterone, because they didn't give them testosterone as well, just DHT, so it shut down estrogen production. Do not significantly alter intraprostatic levels of DHT, testosterone, or prostate epithelial cell androgen-regulated gene expression in healthy men.
That's because their SHBG decreased. SHBG delivers androgens into the prostate. So if you give a DHT gel, it'll bind to the liver first, decrease SHBG production, and not be delivered to the prostate.
Does it decrease it down to the point that it wouldn't deliver any to the prostate, though?
At least a non-inferior or non-statistically significant amount. I doubt the prostate shrunk. If you also account for the confounding variable of CAG repeat number and the androgen receptor, then that will also help stratify the data. In fact, you can go off PSA and prostate size if you start a patient on really any TRT regimen, and assuming you don't have them on any sort of anti-androgen, the increase in PSA and prostate size is very closely directly correlated with their CAG repeat number. So if both double, it's extremely likely that they're very sensitive to androgens.
And this is where, and this is it's a great example of that almost all studies are flawed in some way, because of exactly what I mentioned before and what Kyle mentioned there, these mechanisms. But I guess in terms of, and this is why I really like the study of science, and this is where I think, like ourselves, and I would hope people watching can appreciate the point of science is not to worship it like a religion. It's to use it as a tool to help us understand how the world works. And when I look at a paper, this was only a 4-week trial. I have seen men with 7-fold increases in DHT using bioidentical DHT, anabolic androgenic steroids, and I would argue that there would still be enough SHBG to at least impact the prostate. The fact that there was no change whatsoever in the prostatic environment, as well as other research suggesting that the prostate androgen receptor is saturated at a very low level, I would, I guess, question the hypothesis or notion that modulating DHT levels via using something like dutasteride or finasteride on hormone replacement therapy would be beneficial.
The tricky thing with testosterone that we have to look at is that testosterone is good for you up to the point that it's not. A lot of the anecdotal outcomes as well really conflates bioidentical testosterone with anabolic steroids. Finding something productive and stressful that's got that nice balance that if you got out the other side of it, you'd be like, that would be meaningful. When I was going through my rehabilitation for my brain injury, if it wasn't for the testosterone, I wouldn't have gotten through it, because that was just this insurmountable period of what I would call living hell.